Hi guys, this is gonna be a review about the most important topics for Clinical Skills 2 module. So in this first video, I want to talk about basic life support, or BLS for short, that we apply for adults, children, and infants, as well as using AED and other devices for BLS. So specifically for BLS, we need to define different age groups. So we have adults, we have children, and we have infants. There's like different medical definitions for these ages, but let's stick to these ones for now, specifically for this BLS course. So let's start with adults. So adults include adolescents, and that's after the onset of puberty, and anyone older. And then we have children. So children are between the age of 1 and puberty. And then finally, we have infants. So infants are anyone younger than 1, excluding newly borns, like in the delivery room, for example. So the BLS course mainly focuses on CPR skills. CPR is just this life-saving procedure that includes a series of compressions and rescue breaths, which greatly improve the chances of survival of someone who's had sudden cardiac arrest. So the signs of sudden cardiac arrest include obviously loss of consciousness, and then unresponsiveness, loss of pulse, no normal breathing. This actually includes gasping. So gasping is not normal breathing, and it's definitely a sign of cardiac arrest. First of all, let's talk about what actually constitutes high quality CPR. So firstly, we need to give CPR within 10 seconds of recognition of a sudden cardiac arrest. Secondly, we need to push hard and fast at the rate of 100 to 120 compressions per minute. And in terms of depth, it depends on the age. So for adults, generally we need to give compressions at the depth of around 5 centimeters, which is about 2 inches, I believe. And for children, it's similar to adults, but generally it depends on the size of the child. So if we're talking about like a really small child, then generally the rule is compress at the depth of a third of the AP diameter of the chest, so the anterior posterior diameter of the chest. And then for infants, it's the same. So a third of the AP diameter of the chest. So that's going to be around 1.5 inches or about 4 centimeters. It's important to make sure that we deliver at the adequate depth needed for effective compressions, but it is also equally important not to give too much depth of compression, because that might cause injury. So generally, anything more than 2.4 inches would be considered too much. Again, this depends on the size of the person. Generally, if the compressions are too shallow, then this is going to be ineffective. And if they're too deep, which is rarely the case, then it might cause unnecessary injuries to the chest. The third component of high quality CPR is allowing the chest to recoil after each compression. And this ensures the adequate filling of the ventricles before we initiate another compression. The fourth component is minimizing interruptions between compressions. If we need to be interrupted, then we need to make sure that the interruptions don't last more than 10 seconds. So this, for example, includes like moving the victim from harm or giving rescue breaths. So anything that interrupts CPR has to be like less than 10 seconds if possible. The fifth and last component of a high quality CPR is giving effective ventilation. So when we give rescue breaths, we need to like look for certain signs that this is going to be effective. So we need to deliver each breath over 1 second, and we need to look for the rise in the chest. Moving on to chain of survival. This is on the BLS course and on the syllabus, so I want to go over this really quickly. There are 2 distinct chains of survival depending on the setting of the arrest and the availability of rescuers and resources in the scene. So the first one is in hospital cardiac arrest, and the second one is out of hospital cardiac arrest. Hospital cardiac arrest usually happens when patients have really serious respiratory or cardiac problems that get worse. This usually can be predicted and prevented via careful monitoring of the patient or treatment of pre-arrest conditions. So what usually happens in the hospital is that the primary care provider recognizes the cardiac arrest in the patient, and calls the resus team, and then high quality CPR is then provided, rapid defibrillation is provided. So mainly the survival of the patient depends on the smooth communication between the healthcare staff. Usually after the return of spontaneous circulation, the patient receives post-cardiac arrest care, and this can happen in the ICU or a cath lab. So a cath lab, also known as cardiac catheterization suite or lab, is just a specific highly specialized room or rooms in the hospital. This is where patients go to get their heart and different vessels to be evaluated. Cardiac catheterization is basically a procedure where we insert specialized catheters into the vessels of our patients to evaluate the function and the structure of those vessels. Like a contrast material can be used to generate images to help us, see and evaluate what's going on there. And this might also involve the insertion of specialized catheters to open up blocked arteries, for instance, blocked arteries in the coronary circulation. Out of hospital cardiac arrest, on the other hand, happens kind of unexpectedly, and the survival of the patient greatly depends on how quickly a bystander can start CPR and initiate defibrillation. Just to compare adult cardiac arrest to pediatric cardiac arrest, adult cardiac arrest, they're usually unexpected and due to cardiac or pulmonary problems, whereas with children, sudden cardiac arrest is usually secondary to respiratory failure or shock. Let's talk about the difference between cardiac arrest and a heart attack. So usually these terms are used interchangeably, but actually they are not the same, and they're actually quite different from each other. So cardiac arrest is more like a rhythm problem or an electrical problem in the heart, whereas a heart attack is a clot problem or more like a circulation problem. Cardiac arrest happens when the heart develops like an abnormal rhythm all of a sudden, and this abnormal rhythm causes the heart muscles to quiver. And if the heart is just like quivering, so if the heart is not beating in a synchronized manner, then that means that it's not effectively pumping blood to the brain, to the lungs and other vital organs. This means that the patient will become unresponsive within seconds, and the patient will die within minutes if no life-saving treatment is initiated. So if CPR or defibrillation is not initiated. So heart attack, on the other hand, is a circulation problem. Like I said earlier, so this usually happens when blood supply to a certain part of the heart is blocked, e.g. by a clot, and that stops that part of the heart from getting oxygenated blood and nutrients, which leads to ischemia and then cell death. In contrast with sudden cardiac arrest in heart attack, so the heart typically still pumps blood, but the longer the patient goes without treatment, the more damaged the heart muscles will become. Occasionally, the damaged heart will trigger abnormal rhythms in the heart, and this might lead to sudden cardiac arrest, but not all the time. And there are also other symptoms of a heart attack that is not present with sudden cardiac arrest. So usually patients would complain of central chest pain, shortness of breath, and that chest pain radiating to other parts of the body like the jaw, the neck, the shoulders, or the back. So the BLS sequence for adults, if there's only one rescuer available, is actually quite straightforward. So the first thing you do is assess the environment. So you have to verify if the scene is safe for you and the victim. So you have to make sure that you don't quickly become the victim yourself. So for example, if the building is burning down, then move the patient or move the victim away from any sort of hazards or harm before you initiate CPR. So the next thing you do is you assess for responsiveness. So you tap the patient on the shoulder, shake them a little bit and ask, "Hi sir, are you okay?" And if they're unresponsive, then you need to call for help. You need to activate emergency response system. Activation of emergency response system will vary depending on where you are in the world and the local setting. So for example, if you're in the hospital and you're part of the healthcare team, then usually there would be like a series of numbers you have to dial to summon the resus team or the cardiac arrest team. So the hospital where I worked in, it was 444 4444 or 2222. So there were four numbers, but it's different in every different hospitals and in different countries. And if you are outside of the hospital, if you're in a local place, usually you call for emergency response services by dialing some numbers on your phone, like 999 or something. Once you've activated the emergency response system, then you need to go and get the AED if you're alone, or send someone to get it if someone responds to your call of help. The next thing you need to do is assess the breathing and check the pulse simultaneously. You have like literally 10 seconds to do this. So for assessing the breathing, we need to look, listen, and feel. So you look for the chest rising and falling, which indicates that the patient is breathing. And then you need to listen for any breath sounds, and then you need to feel for any air that's coming in and out of their nose or their mouth. Simultaneously, you need to assess the patient's pulse. So there are a few areas. So obviously carotid, brachial, or radial pulse could be used to assess if the patient has a pulse. The next steps would depend on the situation. So for example, if the patient has normal breathing and has a pulse, then what we do is obviously we don't just leave the victim, we stay at the victim's side till the emergency services come. Just to make sure that the patient doesn't suddenly lose consciousness. If there is no normal breathing, so if the patient is gasping, but there is a pulse, what we need to do is we need to administer rescue breaths. So we need to give one rescue breath per 5 to 6 seconds. So that's about 10 to 12 breaths per minute. We need to stay at the patient's side and check for the pulse every 2 minutes. And we have to be prepared in case the pulse suddenly disappears, to give high quality CPR. If there's no breathing and there is no pulse, what we need to do is we need to start CPR. But before that, we need to take off the patient's clothing so we can expose the chest. And in that way, we're able to locate exactly where we place our hand before we start compressions. And this will also allow the placement of the AED pads when they become available to you. And as I said at the beginning, the compressions should be at the rate of 100 to 120 per minute. And the ratio between compressions to rescue breaths should be 30 to 2. So 30 compressions to 2 rescue breaths. Next thing you need to do is to use the AED as soon as it becomes available to you. So you start by attaching the pads and obviously turning the AED on, but some actually just turns on automatically. It depends on the manufacturer's AED, but again, attach the pads, turn it on, and then usually what this machine does is it will analyze the rhythm of the heart and will tell you if the rhythm is shockable or non-shockable. So shockable rhythms include pulseless ventricular tachycardia or pulseless VTach and ventricular fibrillation. And non-shockable rhythms include pulseless electrical activity and asystole. So if it's a shockable rhythm, then the AED would prompt you to deliver a shock. And then after that shock is given, you need to resume CPR immediately for 2 minutes or until the AED prompts you for another rhythm check. And you need to keep doing this until the emergency medical services arrive or until the patients regain consciousness. And if the rhythm is non-shockable, then you just resume CPR for 2 minutes or until the AED prompts you for another rhythm check. And you need to keep going until the emergency medical services arrive or until the patient regains consciousness. Now let's talk about the proper chest compression technique. So once you've spotted that the patient is unconscious and not breathing and there's no pulse, you move them first into a flat and firm surface. This is because that would just make the compressions more effective. If you attempt to do compressions when the victim is on a soft surface like the mattress, that would just cushion the pressure that you're putting into the chest, so the compressions would not be as effective. So the first step is move the patient on a firm surface like the floor, for example. And then what you have to do is to position yourself at the side of the victim and make sure that the victim is actually facing up. And if you suspect that there's any head, neck, or spine injuries, then make sure that their head and neck is in line with the torso when you rotate the victim so that the victim is facing up. So what you need to do is to place the heel of one hand directly on the center of the patient's chest. on the lower half of the sternum, and then you place the heel of the other hand directly on top of that hand that's touching the patient. And you need to make sure that your arms are completely straight and that your shoulders are directly over your arms and your hands. Every single compression, you need to make sure that the chest completely recoils, because this ensures that the ventricles are adequately filling with blood before you start another compression. And again, the universal rate for all cardiac arrest victims, regardless if they're adults or children, is 100 to 120 compressions per minute. So let's talk about ensuring that the airways are open. So for rescue breaths to be effective, we need to make sure that the airways are open. So we do this in two different ways. First one is called the head tilt chin lift method, and the second one is called the jaw thrust method. So if you suspect any head, neck, or spine injury, then the jaw thrust method would be more suitable, because this would reduce the movement in the neck and the spine. Also, if you have multiple rescuers, the jaw thrust method might be more appropriate, as one person could make sure that the airways are open while the other one provides ventilation through a bag, for example. To perform the head tilt chin lift method, you use one hand and you place the palm of that hand on the patient's forehead, and you just gently press to tilt the head forwards. And with the other hand, you use your fingers, place it under the bony part of the jaw to lift the jaw up and move the chin forwards like that. You have to make sure that you don't completely close the patient's mouth, because that will close their airways. The jaw thrust method is used when the chin tilt head lift method is not working, or if you have multiple rescuers, or if you suspect any head, neck, and spine injuries. So what you do is you place both hands on either sides of the head, with the fingers kind of placed under the angle of the jaw. So you do that, and then you lift with both hands up, and you need to again make sure that the lips are not fully closed, that the mouth is open, to ensure that the airways are open. So we have different barrier devices for giving rescue breath. So the pocket mask is an example of this barrier device. So it usually consists of a one valve system. So this enables the rescuer to give rescue breaths to the victim while diverting the victim's exhaled air away from that of the rescuer. This comes in different sizes for adults, children, and infants. And some of them, they have an oxygen inlet to allow for the administration of supplemental oxygen. The bag mask, on the other hand, is used to provide positive pressure ventilation. And this is usually used when there are two rescuers, because one could do the jaw thrust technique while the other uses the bag mask to ventilate the patient. So the bag mask is a rather simple device. It's just a bag attached to a face mask, and it's self-inflating. The bag is self-inflating, and this can be used with or without oxygen. So if it's used without supplemental oxygen, then the patient is getting 21% oxygen from just the surrounding air. And I forgot to mention that exhaled air actually contains 17% oxygen. So when we're giving rescue breaths through the pocket mask, for example, the patient is still getting some oxygen from our exhaled air. So if we're lucky and we have two rescuers at the scene of the cardiac arrest, then rescuer number 1 could be at the patient's sides in charge for the compressions, and rescuer 2 could be at the patient's head side in charge of the breathing and ventilation. Rescuer 1 would count the compressions out loud, so rescuer 2 can anticipate when the breaths would be delivered, and so rescuer 2 is also aware when the switch is approaching. The rescuers need to switch every 2 minutes or every 5 cycles of compressions and ventilation, or usually when the AED is analyzing the rhythm. And this is done so that the quality of compressions is not compromised due to the rescuer fatigue. It's important to be very quick with the switch, so take like maybe 5 seconds. Rescuer 2, on the other hand, who is on our head side, who's in charge of airway and ventilation, needs to make sure that the airways are patent the whole time, that they are open, and needs to give effective ventilation via either the bag mask ventilation or just rescue breaths. And rescuer 2 needs to encourage rescuer 1 to give really high quality compressions, so getting that depth correct and the rate correct.